Welcome back, Sean Haaverson here. We're going to review the next video in our cardiac anatomy and physiology section, where we focus on the microscopic cardiac anatomy and physiology functions. Now, this is going to be quite a bit more depth than you're used to at the EMT basic and EMT intermediate level, especially if it's been a while since you reviewed this material. So this may require you to spend quite a bit of time focusing on some memorization and, of course, some key concepts. So, of course, pause the video as you go, take notes, and re-watch it if you need to. Let's get started. So when we're talking about cardiac cells, most of our focus, most of the things that are going on in our mind in emergency medicine about the heart is really focused on the myocardial cells. Right, so we got the myocardium. The myocardium was that muscle layer that's sandwiched between some membranes that does the squeezing. It's most thick in the ventricles, specifically the left ventricle, but surrounds the chambers of the heart. And when it contracts, muscle contracts, when it contracts, it causes the chambers to change their size, which changes the pressure of the blood inside of them. The primary cell of the myocardium is called the myocyte. And the myocyte's very, very important, and it has some unique characteristics when compared to other muscle cells. In this video here, or this GIF here, we're showing from cellsalive.com an individual myocyte, so this is essentially one cardiac cell, that is beating, and it's beating over and over again, generating its electrical impulse. Now that beating, that contraction, the cell beating, will lead itself to the heart rate, the pulse, eventually blood pressures and perfusion, but how it generates its electrical impulse is really fascinating. Now remember, just like any other cell that depolarizes in the body, we really don't have some type of battery that's powering this. So we have to figure out ways, our body has figured out ways rather, to create electricity just from the chemical principles and properties of the electrolytes and other chemicals inside our blood. But generally, we'll have multiple myocytes. These are multiple myocytes, all beating together, beating in unison, meaning they contract and their beat is joined. And that contraction allows for not just one cell to change and shorten in size, but the entire tissue of muscle surrounding the heart to shorten in size, which then allows us to have ventricular and atrial contraction. Inside the heart, we have other types of tissue as well. So although we have the myocyte, we have connective tissue. And the connective tissue does not have the same properties of the myocardium. So the connective tissue wouldn't be creating a heartbeat. Connective tissue is going to make up some of the lining of membranes inside the heart. It makes up connections between our valves and some of the valve structures. And it's also a separation line between the atria and the ventricles, in which electricity can't go straight down into the ventricles because the connective tissue lacks the ability to conduct electricity like our muscle cells would. The connective tissue also creates, as mentioned, valves, and the valves are going to be openings between chambers and between blood vessels that allows us to maintain proper blood flow in essentially just one direction. And then finally, as mentioned, the myocytes are the workhorse of cardiac muscle contraction. So let's look at something very, hopefully, a little bit familiar to us, maybe not very familiar, but a little bit familiar to us from our previous videos. We're going to look at the action potential. This time, we're going to look specifically at the cardiac action potential, but the nice thing about this is it looks just like what we've learned before in the skeletal muscle contraction, depolarization, and action potential. Let's now start zooming in to start understanding how electricity is generated, how these cells function. They generate electrical impulses, and how they'll generate contraction as a result of the electrical impulses. So let's start first, though, with something that we have a little bit of knowledge about so that we can orient ourselves to some very, very abstract principles. So let's first start with our EKG, right? We've got our P wave, maybe a Q wave, RS, and our T wave. That's our EKG. So this course is going to prepare us for understanding EKGs a little bit later. And we'll have a little bit of a discussion on basic EKGs here for sure. But to understand dysrhythmias and to manage those dysrhythmias, we kind of really need to have a good understanding of how this electricity is generated. So here's our EKG, electrocardiogram. The EKG is looking at, if you will, it's measuring through a bunch of electrodes. Here's our person. There are a bunch of electrodes on the patient's body. It's sensing electricity as it's originating by the heart. The EKG is seeing the heart beat. And so what it's showing us is all these millions of heart muscles, cells, all these millions of heart muscle cells, it's showing them all generate their electrical impulses, and that's the waveform that we get out of it. Now, if we zoom in, so we've got one cell here, right? We zoom into one myocyte. If we zoom into one myocyte, any one of them, because they're all basically doing the same thing, they're all connected, they're communicating this electrical impulse, they're having similar action potentials because they all need to send electrical impulse and contract to move muscle, to move fluid, to create pressures. All that has to happen in unison. So it doesn't really matter necessarily which one we pick. They're all going to be doing the same thing. But it is that we're picking one. Let's imagine, instead of with our EKG, where the EKG is looking at all of these cells and creating an electrograph, we now look at a waveform, a graph waveform, inside just one cell. So imagine that we have an electrical probe stuck inside one myocyte, one cardiac cell. If we do that, and again, all of these cells are creating this electrical impulse, our waveform will look a little bit different. It'll look something like this. And on our graph paper, this would be somewhere around 0. So it's measuring a similar set of information as the graph we have for an EKG. An EKG is measuring time in milliseconds, and it's measuring amplitude often in millivolts. Well, here we're looking at now just one cell, so zooming in even further, but we're also measuring time and millivolts along the y-axis. So it's the same measurements. The difference is that when we're looking at an EKG, we're seeing many thousands of these, millions of these, all beating together at any point in time. So that's one phase of the electrical impulse. That's one cell doing that, and other cells, and other cells, and other cells, all doing this. But when we look at it from the outside of the heart view, we get the EKG. So we're going to spend our time looking at this waveform here that's showing the electrical depolarization and repolarization cycle of a single myocyte to first understand what's happening in a cell, because we do need to understand how these individual cells contract to give rise to movement of fluid and muscle contraction. Now, we're going to review this a few times, and it's something that I think we need to see multiple times just to make sure we have down before we can assume that we're ready to move on and be tested on it. So again, we're going to review this again a little bit later, but this sets the tone of why we're talking about some of the structures that are about to follow in these next slides. So if we draw this waveform, this waveform in total is showing action potential, depolarization, and repolarization, all again within one cell. So consider this entire waveform is one myocyte beat. That's one contraction, one depolarization of the myocyte, and it will happen over and over again because essentially the heart cells don't get to rest. On my graph here, we have our imaginary line, and there are numbers associated with this, but for our purposes, we don't necessarily need to know the numbers aside from 0, below 0, and above 0. And again, on our y-axis, y is showing us amplitude in millivolts, x-axis is showing us time in milliseconds or shorter. Now, when we look at this depolarization cycle of a cell, we're going to also coordinate this with specific things happening inside of a cell. So these lines where we have our flat line much below 0 before really anything happens is going to be our phase 4. Okay, so phase number 4. And phase 4 is our potential. We're ready to do work, right? We're just kind of waiting. We're waiting, but we're ready. So we can do work. We're ready to do that work. Everything is in the right location, but we haven't depolarized or repolarized. We're kind of in a state in between each beat. The first part of our phase is going to be phase 0. And phase 0 is going to be this rapid upstroke of electrical energy going from a very negative environment to a very positive environment. And really, that's showing polarity. So if we were inside this cell, again, we're measuring inside the cell, we're saying the inside of the cell is very negative at this point. And the inside of the cell being very negative is in contrast to the outside of the cell being very positive. And so we have electrical polarity, right? Polarity means kind of the extremes, the opposites of extremes from one end to the other. So the difference between these two, if we're just talking about being positive and being negative, that's polarity. We are polar opposites of this other charge. So we're polarized by having a negative charge inside of the cell. During phase 0, we're going to have a rapid uprise of electricity as energy rushes into the cell. And that energy is going to be in the form of sodium ions. Sodium rushes into the cell. So as sodium rushes into this muscle cell, the inside of the cell now becomes very positive. We end up at this point. And that is a reverse in polarity. So phase 0 equals depolarization. We went from one polarity to the other polarity, from negative to positive inside of the cell, and that is depolarization. Once that occurs, we now have a very positive charge inside the cell, and we reach phase number 1. And phase number 1 is going to occur when our sodium channels that allowed that ion charged with positive charged energy to rush into the cell, those channels close, and sodium stops going into the cell. Once that occurs in time, the next step is going to be phase 2. And phase 2 has to do with this plateau, this kind of flat area that we have that's between our downslope and the upslope that we just went through. Phase 2 is going to be a time when the inside of the cell is held in a positive charge for an extended period of time. And the thing that holds that charge is going to be the release inside the cell of calcium. And calcium, as we might recall from previous training, has 2 or double the positive charge of sodium. So calcium is going to hold this positive charge inside the cell for a period of time. And this is, if all things were connected, when, but we can't always rely on it, but this is when contraction might occur. The muscle cell contracting occurs generally during this phase of the plateau, or phase 2. The next phase is, as we get out of the plateau, phase 3, we're starting now to go back to our state where we're very negative inside the cell so we can do work again. And in that state, we need to go from a positive charge on the inside of the cell back to a negative charge. So we're going to reach polarity again, and this phase is called repolarization. We repolarize from being positive inside the cell now to the polar opposite, negative inside the cell. So during phase 3, a few things are going to happen. Those calcium channels that open are now going to close. So calcium is no longer being released in the cell. It'll eventually diffuse, fall out of the cell, and the positive charge that calcium had with it will go away. Potassium channels will start to open. And potassium channels are important because potassium is the electrolyte that's most abundant inside of these cells when we're ready to do work. So potassium is what helps us get to a negative charge. Potassium channels opening allows for us to kind of get closer to 0. But once we get 0, that means that we have no charge. At 0 on this graph, as we're moving down towards negative land, on 0, that means that we have an equal charge on the outside of the cell as we do on the inside of the cell. There's no difference between them. But we need that difference in polarity for work to happen. So at this point, we have to do something by working against the gradient, or working against that equilibrium. So to take us from equilibrium now to a place where we have a polarity again, we need to utilize pumps. And specifically here, the sodium-potassium pump that we'll review through this lecture is going to start working to pump sodium-potassium against this equilibrium and to create our polarity. And eventually we will get back to phase 4, where we're now ready for another action potential to occur, ready for more work to happen. And notice at phase 4, we are very, very negative. So we've reached polarity again. Now, kind of hold with this idea. These are some of the steps that are occurring. We've got to kind of unpack this a little bit, but we are going to explore how this electrical waveform or graph is generated in the process of depolarization. Before we do that, though, let's talk about these electrolytes that I just laid out on our graph. In our electrolytes, we have an opportunity in which our chemicals, these electrolytes, meaning that we have chemicals, molecules, atoms that have a charge, right? That's what an electrolyte is, a chemical that has a charge. So chemicals can have positive and negative charges. We're going to focus primarily on our cations. And cations, cat with a big old positive in the middle, cations is the name for positively charged ions. Now let's go through some of the electrolytes that will help us achieve this function. And we've talked about some of them, but not all of them that are on this list. And we'll also talk about other chemicals that are important in the cell's working. We'll talk about calcium. Remember, calcium is what gives us that very positive charge. Calcium has 2 positive charges associated with it, so it's a very positive cation. Potassium. Potassium was the electrolyte that needed to get back into the cell. Potassium has a single positive charge. Sodium was the electrolyte that needed to go from the outside of the cell into the cell during depolarization. Sodium is the ion that allowed for depolarization, and it has a single positive charge. And then magnesium plays a role in multiple cells throughout the body, and since we're talking cardiac and vascular, it's very important to understand for smooth muscle. Magnesium is also a cation, but it has a 2 positive charge, just like calcium does. So now let's go through and talk about what each of these individual ions do to allow for our myocardial cell or a myocyte to depolarize. So some general facts about each of these. Calcium, with 2 positive charges associated with it, is the most abundant cation in the body, like in total. Calcium is generally going to be stored in areas like our skeletal muscle and inside of our bones as well for use later on. Cardiac function as in calcium. Calcium's cardiac function helps to contribute to that positive charge inside the cell. So remember, after we depolarize, the plateau here, us staying positive for a period of time, is because of calcium. Calcium is also required for the contraction of muscle cells, which we'll get into in just a moment. This is very similar to what we may have discussed before in skeletal muscle and has the same role as it does in cardiac muscle. It also is going to affect the strength of contraction when those muscles contract, like our ventricles. Now, calcium is going to be stored in cells and inside bone, so generally when we're looking at blood, we find that the calcium concentration is not very high. We'll find that other ions that exist outside of cells, for the most part, have a much higher blood concentration because if it's supposed to be in a cell, then it shouldn't be in the blood. So the normal blood value for calcium when we're doing blood chemistry is 8.5 to 10.2 milligrams per deciliter. Potassium is a major intracellular cation, so it exists primarily stored inside cells, like our muscle cells. It's going to affect the cardiac system because each of the cardiac cells, or myocytes, has leaky potassium channels, which allow potassium to move from inside the cell to outside the cell when depolarization occurs. It's very important in the conduction of electrical impulses and muscle contraction. It affects the rate of contraction, and when you think of potassium, I want you to think of repolarization. Potassium, very much like calcium, is supposed to be inside of cells, again, intracellular cation. So its concentration in blood is very small. Normal concentration of potassium in the blood should be between 3.5 and 5 milliequivalents per liter. Sodium, which we've discussed multiple times throughout previous lectures, including those of the depolarization of neurons, just like potassium, is a major extracellular cation. So where potassium was our major intracellular, inside the cell cation, sodium should exist outside of the cell. Because it exists outside of the cell, it has a pretty high blood concentration compared to the other electrolytes. It should be in a concentration in blood chemistry of 135 to 145 milliequivalents per liter. And that again just gives rise to it's supposed to be outside of the cell. Sodium plays a role in our depolarization phase of electrical impulses. As it did in the neuron, it does in skeletal and cardiac muscle. So it's important for the conduction of electrical impulses and muscle contraction, and it impacts the rate of contraction as well. Magnesium plays multiple roles in the body, in the cardiovascular system specifically. So here we're going to focus mostly on some of its roles in the heart. Magnesium has a 2 positive charge, and very similar to calcium and potassium, it generally exists inside bone and inside cells. So generally, we don't see a large concentration of it in blood chemistry, not like sodium where we're in the 130s. Here we have 1.7 to 2.2 milligrams per deciliter of concentration, again, because it's usually stored in other places. Magnesium works to mediate intracellular potassium replenishment in the depolarization and repolarization cycle. So it allows us to maintain the difference in charge or polarity on the inside versus the outside of the cell. Here's a list of some other blood values, including the electrolytes for cardiac tissue. So these might be lab values that the ER will draw or the hospital will draw in maintaining and monitoring patients that have potential cardiac complaints. Albumin is the most abundant protein in the body, and it works to help us create a certain concentration and viscosity of blood. And its concentration in blood is 3.4 to 5.4 grams per deciliter. And notice that this is grams, where everything else here is pretty small. Albumin is a very large protein structure, and so it's measured in grams as opposed to some of our lower measurements. Blood urea nitrogen is a descriptor that is the result of energy production and tells us a little bit about the function of evacuating things like urine and other concentrates out of our blood supply and into the kidneys. As mentioned, calcium is used for muscle contraction and holds that positive charge inside our cells' depolarization. Chloride is the most abundant anion in the body. So it's a negatively charged ion and has similar properties where we find sodium. Carbon dioxide is measured in the blood as well as creatinine. Glucose must be available for cells to do their work. CO2 is the result of that, and creatinine is the result of ATP production. Magnesium, as mentioned, 1.7 to 2.2 milligrams per deciliter. Potassium, mediated by magnesium. Potassium is our major intracellular cation, 3.7 to 5.2 milliequivalents per liter. Sodium, we've mentioned. Total protein is a count of the overall protein, including albumin, concentrated in our blood. And that includes things like immunoglobulins, platelets, and other protein structures. Anion gap is a measurement that helps us determine blood chemistry and the difference in patients' pH. There's also other measurements that can be useful in cardiac tissue and cardiac lag values for the hospital. Now, because of these electrolytes, we do get, and because of the functions of skeletal and cardiac muscle, we do get some properties within the myocyte that some are shared with skeletal muscle and others are unique properties of the cardiac cells. So let's focus on the unique properties of cardiac cells. CARI is an acronym that can help you memorize these unique properties, but these properties are important in understanding how electrical impulses and pulses are derived in both normal functioning heart tissue and heart tissue that's experiencing disease or abnormalities. C stands for conductivity. Conductivity is the ability of cells to conduct an electrical impulse from one to another. And that means that we can rely on cells to send the signal between them without having to have constant nervous system signals spread throughout the muscle fiber as we find in skeletal tissue. This allows for very efficient and rapid conduction of electricity between cells through the entire heart so that the heart works to constrict, create pressures, contract, and all of that on a specific cycle, allowing for optimal perfusion. A, automaticity. Automaticity is the ability of these cells to generate their own electrical impulse without receiving any signal from any kind. So these will allow our cells to generate their own beat normally and when there's a problem that's not allowing electrical conduction to travel through the heart fully. This essentially helps keep us alive in emergencies. Rhythmicity and regularity is what the R stands for in CARI. This is the ability of these cells to beat in a rhythmic unison, so they create, as you know, a heart rhythm that we can detect and feel as a pulse. I is for irritability and E for excitability. But let me actually start with excitability first. Excitability is normal. Excitability is the ability of the cell to receive the electrical signal that was sent by conductivity and then be excited by it to generate another electrical impulse. So it responds to the signals that are coming through it from around it. And that's a normal process of transmitting electricity through these cells. Irritability is kind of like excitability, but it's the abnormal version. Irritability is the ability of the hearts to generate their own electrical impulses as a result of having some problem with the cell. That could be from periods of low oxygen, high CO2, low pH or high acid concentration, not having enough glucose, electrolyte imbalances, and so on. But when the heart has an environment that is not optimal for it to work, it doesn't just stop working, thankfully, or we would be dead anytime we got a little bit dehydrated. So irritability is a means of keeping our heart alive even when or because of the problems that the tissue is experiencing. This can also lead to some abnormal electrical rhythms called dysrhythmias. Some of those are found kind of commonly without causing a lot of problems, like PVCs or premature ventricular contractions. Now, muscle cells also have properties that there are shared with cardiac cells from skeletal muscle to cardiac, but one of them that we'll focus on is contractility. Now notice I didn't list that in the other list, although some texts do, but I want to make a very clear distinction at the paramedic level that contractility, or the ability of muscles to contract, as you can imagine, all skeletal muscle contracts, all smooth muscle contracts, so all muscle is contractile. So contractility is a mechanical process, very important. This is mechanical. Not only is it not unique to the heart, but it's not an electrical property of these cells. And so there is a very clear difference between the electrical properties of cells and the mechanical properties of cardiac cells. Why do I bring this up? Well, something that you're going to be confronted with when you start learning about situations like PEA, pulseless electrical activity, where our EKG maybe looks very nice, but it's not resulting in a pulse. When we have organized electrical activity and no pulse, that means that the electrical system is working at least somewhat, but that is a clear disconnect between our mechanical system, which generates the pulse. So you do need to, in your mind, separate these two systems, because just because you have electrical conduction does not mean that automatically you have mechanical conduction. An example of that being PEA, in which you have clear electrical conduction, but there is no automatic mechanical conduction that goes with it. So electrical conduction and properties are distinctly separate from mechanical properties like contractility. So start that separation in your mind now to save you some headache in managing patients later. Hey friends, I just wanted to throw out there another reminder on this I forgot to mention in the video. So clearly, when we're talking about electrical activity in the heart, we do want to separate that electrical activity does not automatically mean that there is mechanical activity. Meaning when there is electrical activity, it doesn't automatically mean there's a pulse. So of course, we need to be assessing pulses. But another area, especially for new paramedics and paramedic students, that trips them up on this specific issue, electrical versus mechanical actions of the heart, is when we're managing patients with pacing. And so another reason that you want to disconnect the electrical and mechanical connections in your brain from being automatic is that when we're managing patients with bradycardia and we need to start pacing, we need to confirm that we have electrical capture, a process that's described in other areas and other videos, so I'm not focusing on the process for right now. But when you have electrical capture, that means that your pacer is making the heart do what it wants electrically. You're creating your heartbeat. That doesn't mean that we have a pulse. So we also have to check for mechanical capture as well. And mechanical capture then shows us that, yes, we have electrical activity from our pacer, our monitor, our life pack, whatever it is that you're using. And then also it is really leading to perfusion. And so another reason why we want to disconnect electrical and mechanical activity in the heart for paramedic practice. All right, stay safe. Now let's change platforms and we're going to look at the structures of a myocyte, really just looking at the main components that we need to review in how a myocyte works and orienting ourselves to the inside of the cell. In this brief video, we're going to look at some of the internal workings, just the setup of the myocardial cells, so cardiac muscle cells. So here we have kind of a familiar setup, and this will be very similar to what we've talked about before in some of my videos leading up to this in skeletal muscle. And at a later date, we'll zoom into this and look at its working as how it depolarizes and eventually leads to contractions. But let's first start just with some primary orientation to this cell structure. So as a muscle cell, very similar to skeletal muscle cell, the cardiac muscle cell has a plasma membrane. So that's what we have here. And the plasma membrane separates the outside and inside of the cell, the extracellular environment, from the intracellular environment. The plasma membrane has some familiar structures embedded in it. So we're going to have some things like sodium channels. Let's say they look like that. We'll have potassium channels. Let's make those look like that. We'll also have calcium channels because we do need to replenish the calcium that we're going to be using inside these cells. And again, very similar to the structures that we saw inside the muscle cell. We also have the sodium-potassium pump, so draw that something like that. And that pump is going to pump out sodium and pump in potassium at an unequal rate. So usually each pump stroke is going to be 3 to 2, 3 sodium to 2 potassium. Now we have receptor sites too that are attached to some of our channels, and the receptor sites will allow for the receipt of neural conduction that tells the cell to do something differently in its functioning. Inside the cell, inside the sarcoplasm, or the space that makes up the fluid contents where organelles live, inside the cell we have a container, again very similar to the skeletal muscle cell, called the sarcoplasmic reticulum. And the sarcoplasmic reticulum, sarcoplasm, so the inside of the cell, of a muscle cell, and the reticulum is a storage area. And inside this, we have a collection of calcium. So this is the calcium storage site. And calcium is going to be very necessary in the function of our cell contracting in just a moment, just again, as it was in skeletal muscle. This structure, connecting the plasma membrane, the sarcoplasmic reticulum, and the indentation inside the sarcoplasm, is going to be the T-tubule. And the T-tubule functions as a means of communicating once the outside of the cell depolarizes, when it's received its signal from nearby, to allow the cell inside to release calcium. So that's the major structures. Over here, I just drew for a reminder, there are other organelles, but we do have our mitochondria. And as you imagine, cells going to do work, so the mitochondria's role is to create ATP, and it does so by bringing in and utilizing, in best case scenario, oxygen and glucose. All right, and again, certainly many more organelles. Now, the structure of the cell that allows for contraction is a muscular structure, very similar to skeletal muscle. And so we have the combined motor unit here that incorporates the thick and thin filaments. So let's label these structures as well. And of course, I've kind of, made them a little bit larger. We would find that we have bands of these collected throughout the cell so that it can do its very, very important work. Now, the primary piece of this puzzle is to realize that this is all made up of protein structures for the most part. And proteins, functional proteins, muscle makes very much sense, right? Proteins are sensitive to pH environments. So you want to keep in mind with these cells that if the pH environment gets a little bit too acidic, remember what that does to proteins. It makes them denature, it makes them unravel. And so these are very tightly raveled structures of proteins that serve a physical structure so that they can then serve their purpose of sliding along one another to allow for muscular contraction. So generally we have actin and myosin. Myosin has these particular heads here, and those are the heads that will attach to the actin, and when they attach, they bind in such a way the filaments slide, and that allows for contraction. And we'll also go through step by step the actual process of creating a contraction, depolarization, and so forth. This is just the structures. Now these little structures here are very, very important. So let me highlight this little blue band, and the blue band is going basically across and around the actin structure, and it's covering up, as you can see, the binding site, these little depressions in actin that myosin will want to bind together. So on the side here, I'll just draw what that would look like so we have a little preview. So here's our actin, here's our myosin. Myosin, as you can see in the internal design, is separated. They're not connected, right? They're not connected. But once they connect, they will facilitate this binding site, and then once they bind together, the myosin heads will cock, and the filament slides, and that slide allows for the shortening of these muscle fibers. And so we have a muscle fiber that's this long, and now it will contract and be this long, and that allows for physical movement. Now, around the actin and covering the binding sites are two important, again, protein structures. So this pale blue structure is going to be tropomyosin. And the little red structures that I have here are going to be our troponin. And troponin, very important chemical. These facilitate the blocking of the binding between actin and myosin when there's not muscle contraction. But when there is a muscle contraction, troponin and tropomyosin will roll out of the way to open up these binding sites. And that looks like something like this, where they're now no longer blocking the binding site, so binding can occur and contraction. So what we're seeing here is this is the relaxed state of this muscle cell. All right, so those are the major structures. So just reviewing, our sarcoplasm is the inside of the cell. The muscle cell has an outside lining, the plasma membrane. The membrane has in it a variety of channels and communication signals, including sodium, potassium, calcium, sodium, potassium pump. Inside of our muscle cell, we have the sarcoplasmic reticulum, and the sarcoplasmic reticulum stores calcium for release a little bit later. The T-tubule is a connection between the plasma membrane and sarcoplasmic reticulum, and that allows for communication when the cell depolarizes to tell the sarcoplasmic reticulum to release calcium into the sarcoplasm. And then zoomed into all these muscle fibers that we have, if we zoom in, we find we have actin myosin, troponin, tropomyosin, and they all work together to allow for relaxation and contraction. And ATP is utilized in this process, being generated by the cardiac cells, mitochondria. Now, again, this is just a review of some of the major structures. We're going to talk about how these and zoom into how these structures work to result in depolarization and contraction in a next segment. Great, now let's continue our discussion on cardiac microscopic anatomy and physiology. Since we introduced the inside working of the electrical contractility and the structures that allow that to occur, mostly being protein structures, including structures like troponin and tropomyosin, let's talk about cardiac biomarkers. So if a patient goes to the hospital with a complaint of chest pain that we suspect is cardiac in origin, suspecting perhaps an AMI, it's likely that the hospital is going to draw troponin levels in addition to the lab values that we've discussed so far and doing an assessment and an ECG. The purpose of drawing troponin levels is to determine whether or not troponin is being released by cardiac cells and in the bloodstream for detection, because that generally only occurs, troponin being a structure inside the cell, it only leaks out of a cell, generally when the cells die, like the result of a heart attack. So troponin has multiple types. The types we're going to focus on are type 1 and type T. Cardiac troponin 1 and cardiac troponin T are troponins that are specific, although not exclusive, to the heart. Now, they could be present in other areas. So the presence of troponin by itself may not necessarily mean that the patient is having a heart issue. It's the combination of these values rising when we have signs and symptoms and other confirmation measurements that tell us that they're having a heart attack. That's because skeletal muscle and smooth muscle, like cardiac muscle, also have these types of troponin. Now, these types of troponin can be measured by drawing blood, and they're generally measured at the time of admission when the patient arrives in the ER, and then tested 1 to 4 hours later to determine whether or not those values or troponin levels are rising over time. Troponin could be present in other situations because it's in skeletal muscle, in which skeletal muscle breaks down and it's released. Here's a picture again highlighting the location of troponin, the different types of troponin, and the connection between troponin and tropomyosin. So we have our actin filament here, we have tropomyosin as the red line, and we have a few types of troponin surrounding the site that actin and myosin will use to bind together. In this diagram, we can see how the association between clinical symptoms, ECG changes like ST depression and elevation, and troponin levels tell us whether or not we are suspecting in the hospital the patient is suffering an MI. So when the patient has low likelihood of myocardial infarction, they have a normal ECG and an almost absence of clinical signs and symptoms, there should be no troponin free floating because it's assuming this just started, cells haven't yet died, and they haven't released the troponin that's inside them as a result of dying because of the lack of oxygen, the lack of blood supply that occurs during a heart attack. But as you can see, at some point, once ST depression leads further into ST elevation, in this direction, we see more and more concentrations of troponin at both zero level, and then after we recheck it again later, 1 to 4 hours later on the line. So generally, when patients are suffering with acute signs of a cardiac event, we rule out an MI with the conjunction of signs and symptoms, the ECG and troponin levels, and the overall assessment in the patient. In the next section, we're going to review the cardiac action potential.